Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Akram Alshirah. I am periodontist, DDS from Damascus University, Syria, Master from Duisburg Essen from Germany, and PhD from College of Medicine, Dentistry, and School of Pharmacy, Pharmaceutical Sciences in Ulster University, United Kingdom. This building is the CMB building, and this building I worked in the whole floors in it. So during my PhD work, I was busy and doing my PhD work in platelet concentrates, new generation of the CGF generations. So I worked in the first floor, ground floor, first floor, second floor, and the whole and experiment were held in this building. Very lovely area, and it's from the amazing memories. So I will start talking about the new generations, autologous plated concentrates, new generations, and clinical applications. So I will try my best to keep it like short, spot on, rather than consuming the too long time. The I want to convey a message. When you try to build something, especially when you are doing bone grafting, so it's similar to the nature rules. This bridge is called Bondo Guard. This Bondo Guard bridge was built about roughly 2000 years. So this bridge was built in the southern part of France. Until this moment is pristine, valid, does its work, no problem with it. So in spite of the huge amount of disasters and storms, rains. But on the right side of this picture, you can see here the bridge near to Dead Sea here in Jordan. You can see within the first floods, the first storm, heavily raining days. So you can see the outcomes like destroying everything. And this is similar to the bone grafting. So I want to end with like bone grafting in the left side, 2000 years, and not in the right side. Why? Because we followed the rules of the architecture, the engineering rules. So we didn't ignore the ABCs of the architecture or the engineering principles. And similar to this case, you can see here, I can mimic this to the, what do you call it, the autologous bone graft. So this is autologous bone graft, and this is the like with principles, taking care of the principles of autologous bone graft, like GPR, GTR, etc. Especially the principle, I like it too much. It's PASS principle, PASS. You know the details of that principle. And here, there's even with xenograft or allograft or alloplastic materials, but they didn't follow the rules of the bone grafting. You can see that I don't want to end with the right side of the picture. I want to end with the left side of the picture. And you know that the bone grafting materials, it's divided to four categories. Autologous, allografts from autologous from the same patient, allografts from the same species, the xenografts from the other species rather than the human, like animals, for example, and alloplastic materials like hydroxyapatite, tricalcium phosphate, and amongst other. So those are the types of bone grafting materials. With bone graft, autologous bone graft, we have plenty of techniques. We are dealing with, for example, only block graft, like we call it onlay or block graft. Hori technique, for example, as well. We have like bone ring technique, and distraction, osteogenesis, horizontal ridge splitting, and vertical ridge splitting, guided bone regeneration, and sinus lifting. These are techniques to like making the bone augmentation. But you can see here that like morbidity, the huge amount of complication could happen behind after doing those procedures. What are the merits of autologous bone grafts? You know that autologous bone grafts, it's osteogenesis, osteogenesis, like I have osteoblast. It's osteoinduction. and osteoconduction. I have growth factors. I have morphogenic proteins. I have scaffold. So it provides me with the whole amount of the principles of all these factors. So furthermore, there's less of graft rejection because there's a code. There is a code from the same person. It's biocompatible. It's accepted, and there's no. It's small rate of rejection and reduced cost. Roughly, I can say it's roughly, and furthermore, I can increase more. This autologous bone graft, it has immunology, it has immunity. So whenever it's exposed to the oral cavity, it will like resist the bacterial invasion. It will resist the failure at the end of the day. So there's a resistance, there's a defense, and as a mechanism of the autologous bone grafting. So what are the problems or the drawbacks of those materials? Morbidity. You will see the patient will come at the middle of the night. They will call you, and they will end. Sorry, they will call you that they will say bleeding, sorry, bleeding, there's swelling, there's erythema, edema, swelling, morbidity, so severe pain, etc. So if whenever we can approach any technique to minimize using following this material like autologous bone grafting, it's better. You will increase surgical time, and I think the majority of you know that the people they are following the autologous bone harvesting from the chin, from the ramus, intraoral or extraoral. They will not repeat the same experience of the autologous bone grafting from the same body. They will say, we spent too long time, it's painful, we have surgery here, we have surgery there, so I will not repeat it again. So sorry. So apart from resorption, in the some cases you will find after 1 year, no more than 25% available from the graft itself. So if I want like 10 millimeter and it was like after 1 year, you will find 2.5. 2.5 remaining of that graph. So it's not that big like gain or beneficial of the procedure itself. That's why we are hoping to deal with another techniques. I will talk about it later. So this is a very important slide. So to be honest, this slide is enough to make a clinical decision for you can just make a management with regard the best choice with regard the outcomes. So the best outcomes choice is with a revascularized bone graft. This is in the rank number one. Distraction osteogenesis. You will see the distraction osteogenesis, the number two. What's the criteria? The criteria is about the bleeding surfaces. Whenever I have larger bleeding surfaces, I will say it's more beneficial, more successful. So distraction osteogenesis and inlay. So inlay is number three. And whenever I go down less than this numbers of like bleeding surfaces, I will say it's less successful than the other technique. Then after that, I have only like bone block, or anything like one surface of bleeding. So here, like bony surfaces, like one bony surface is bleeding here. So I rank it as number four. And it's not allograft. Here you can use allograft, xenograft, etc. But here I'm talking about the guided bone regeneration because there's no osteogenesis here you see here. So I can say in the whole techniques before I have the osteogenesis, osteoinduction, but the last one maybe I have induction and conduction, but I don't have genesis, but still have one surface. Memorize this figure. It's very important to manage the decision in your clinic. That's why we turn to another alternatives to autologous bone grafting. We turn to using the allograft, xenograft, and alloplastic materials. It's like the allografts, we can find some of them in as inductive, conductive, xenograft, inductive, conductive, but with regard to alloplastic materials, it's osteoconductive. So the problem with those materials, it doesn't have immunology, it doesn't have immunity in it. So whenever it's exposed to the oral cavity, so you'll see a lot of bacteria invade that area and it will fail it. So at the end of the day, you will not find any material. So there is no leukocytes, there is no defense mechanism. So whenever I have oral cavity exposure, you will say, especially if I'm using the collagen membrane, you will say it's invalid. You have to curate it and extract it. So this is from the limitation. That's why we are using the platelet concentrates. So it's like in a medium, you have to take it auto. You have to take the alternative bone graft. You can use allograft, xenograft, and alloplastic materials, but I quit using the autologous bone grafting rather than I'm using the platelet concentrate because the whole immunity is existed. I have scaffold, but there is no resistance. So I can mix this with that. So I can gain the immunity, I can gain the induction efficacy, and I can gain the induction of the mesenchymal stem cells or hematopoietic stem cells, combine it with the bone grafting materials. At the end of the day, I will have the mechanism in somehow to the level of autologous bone grafting. Okay, so I will talk about the composition of the platelet concentrates. I can see, the blood composition is RBCs, red blood cells, white blood cells, leukocytes, and platelets. And during my preparation, the clue is the separation cells layers in layers according to the density of each layer. So you will see that RBCs at the bottom, the RBCs, red blood cells at the bottom, and leukocytes in the middle, buffy coat layers we call it, and the platelets in the superior area. So we can talk about the generations in general. The first generation is called platelet-rich plasma. Platelet plasma was developed by Marx 1998. There was using of the anticoagulant, which is the EDTA, and it's like anticoagulation material. After using the anticoagulation and centrifugation, soft spin, hard spin, etc., they use the procoagulation, which is the bovine thrombin. And this is one of the limitations as well in the literature of using those materials. Then later on, year after that, Edward Denetwa came and produced the plasma-rich growth factors by changing the bovine thrombin and the EDTA. He replaced it with the sodium citrate and calcium chloride as a procoagulation. Later on, Chakroon and the team, they developed the protocol called platelet-rich fibrin, and it was 2001. The clue behind that is the remove or quit using the anticoagulant. This paper as well, I really recommend using and reading this paper, the categorization platelet concentrate by Al Hussein and Marsafi, 2023. Is very interesting paper. You can download it and you can read it. So they categorize the generation of platelet concentrates to first generation, which is the platelet plasma, which is divided to leukocyte platelet plasma and pure platelet plasma. Pure platelet plasma is most likely is the PRGF, and the second generation, which is the PRF, platelet fibrin, leukocytes and pure, mean leukocytes and without leukocytes. Third generation is the advanced PRF plus injectable titanium, concentrated growth factor CGF, and the autologous fibrin glue with sticky bone. And the new advances, it's very interesting as well. We didn't do, to be honest, any research about that, but I'm doing some research in that third generation, and I developed new generations of the new advances generation. Here, the human platelet lysate and platelet extracellular vesicles, lyophilized PRF and albumin PRF. So these are the advances. And my work during my PhD was in the new advances generations. So again, PRP was developed by Rupert Marx and Aaron Garg, and it was prepared by two cycles, two spins. The first one is soft spin, and the second one is the hard spin, and it is basically according to the if you want it pure or if you want it with leukocytes. So you can include the buffy coat layer or you can exclude it. Accordingly, you can gain the final product. But furthermore, I saw in the literature during my revision, I found that plenty of variations in the literature talking about the speeds of the preparation of platelet plasma. Some of them they're talking about 150 G-force and 250 G-force for 10 minutes and 15 minutes. And some of them they're talking about 1,500 till 2,500. So there's no standardization for the protocol. That's why in literature you will find a lot of variables. No specific criteria and protocol is followed in the preparation of platelet-rich plasma. And later on, as I told you before, we talked about the PRGF. Edward and it was talking about the platelet, plasma growth factors by changing the anticoagulant and the procoagulant with sodium citrate and the what do you call it, calcium chloride. So sorry. Okay. And this is the technique of preparation of plasma rich in growth factors. It's the first step, centrifugation, collection and centrifugation. You can see the PRGF is accumulated and gathered above the buffy coat layer. You can pipette it. You have to be accurate, and this is from the limitations as well of the PRP and PRGF. Like you have to be accurate to collect exactly, sometimes one half mil or quarter of mil above or under, you will change the component. That's why this is from the criticism of those generations. Later on, Joseph Chacron and David Dohan, they introduced the platelet fibrin 2001. They introduced later on another technique called leukocytes and platelet-rich fibrin by Nelson Pinto and Mark Quernin. It's an overall revision of the speeds and the duration of the preparation. By the way, this table is not accurate, but I bought that table intentionally because they changed. We have new protocol, new recommendations, but as we are not following the RPM round per minute, we are following the G force, the RCF relative centrifugation force, or the G force, gravity force. Here the LPRF, you will find like 2700 RPM, or you can find in some references like 3000 RPM for 12 minutes. Titanium is the same as well. APRF, you will find is 1500, or the majority of references talking about 1400 for 14 minutes, while the injectable PRF is 700 RPM for 3 to 4 minutes. But if I want to use the G force, it's another like 60 G force, G force and or RCF. CGF, it's like multiple intervals, and this is my PhD work, was working with this generations and develop new generations of that CGF. So from 24 to 2700 RPM, but 24 indeed, it's to be accurate, 24 to 3000 RPM for 14 minutes. Yeah, I intentionally bought that because I found it in literature. So autologous fibrin glue, the same but for shorter time. And the new recommendations, it's written in the Myron 2025 narrative review. Essential recommendations for PRF preparation. First of all, you have to be fast in the drawing blood. No anticoagulant. Whenever you prepare your tubes, you have to be fast in the drawing blood. Then you have to start spinning immediately. They say that there's a rule to spend not more than 60 seconds up to like 90 seconds between the drawing of blood and the starting of the centrifugation. So pay attention for that. Pay attention to that, to not spending more than this time before the drawing, between the drawing and the centrifugation. Furthermore, you have to make a balanced distribution of the tubes. Otherwise, you will not find the good results or the standard results. Don't pop up the lids following a spit. So we have to spend like 5 minutes and more. I would rather to 10 minutes or 15 minutes and even more if you can. Just you can increase the amount of the clot itself whenever you give it like longer time. So it's essential. Draw the blood, centrifugation immediately, and you have to PRF procedure or preparation. So here, furthermore, you can see here the cells types and the composition of platelet concentrate, especially PRF, for example. I have different types of cells like platelets, leukocytes, and red blood cells in the bottom. And here you can see here the provisional extracellular matrix. It encompasses that composes of fibrin matrix, including fibronectin and vitronectin. The important ingredient of the platelet concentrate is the PRF, for example, is the growth factors. Growth factors, I have PDGF, VEGF, vascular endothelial growth factor, platelet-derived growth factor, insulin-like growth factor, epithelial or epidermal growth factor, and transformer growth factor beta, and bone morphogenic protein, amongst others. We have plenty of types, plenty even from each growth factor. We have plenty of growth factors, but this is like a general clue. So what is the function of each specific growth factor? We have vascular endothelial growth factor. It's responsible of the angiogenesis. So PDGF, basically, it has plenty of things. From the prominent aspects is the recruitment with chemotaxis of the cells, and the transformer growth factor. This is the majority of the available growth factor is TGF beta. It's responsible of the proliferation, and it does do a lot of things, but from the prominent function is the transformer growth factor. Quick revision, according to the like RPM and G-force and the chronological development of the plate concentrate. You can see platelet-rich plasma, 1998, the G-force 1500. So you see here, it's different from the 150 to 150. So it's like 1500 G-force. And the LPRF, in some literature, they're talking about the 27. Some of them they're talking about that 30. What's the difference between them? It's about the radii. So it's the radius of the centrifugation, the centrifuge itself. This radius it does control the g-force. So there's a specific equation between the RPM and the g-force. So 700 g-force. Now in new regulations, new rules, now they excluded the criteria of RPM. They are following the only g-force. Don't tell me anything about the RPM. Just I will accept it. Even with a new recommendations, guideline, protocols, like it's accepted to narrate or to mention the G-force only. Advanced PRF, it's 200 G-force, but for 14 minutes. Advanced PRF Plus is 200 G-force, but for 8 minutes. And injectable PRF is 60 G-force, but for 3 minutes. While the BioPRF, which is the horizontal PRF, and this is the horizontal PRF is for the I will change it. Sorry. So it's for 700 G-force, similar to the LPRF for 8 minutes. So you can find it some recommendations they recommend to 12, but 8 minutes 700 G-force. Okay. So now new generations was introduced is the LSCC, which is the low speed centrifugation concept, was developed by Ganati and Fujiak Kobayashi, Masaoki Kobayashi. And this preparation, talking about that, it decrease the g-force and decrease the time as well. So here, differentiate between the APRF and APRF plus. You can see the amount of the clot itself is less because it's centrifuged for less g-force and some of them less time, both less g-force and less time. So you can see here in the bar graph, you can see the amount of leukocytes. It's more with the APRF plus and higher than both APRF and PRF. So you can see here in the as well for VEGF, vascular endothelial growth factor, you can see the amount of growth factor is higher in the APRF plus. Similarly, with regard transformer growth factor, you can see the amount of TGF beta, which is the highest amount, the most popular growth factors that existed in the platelet concentrate is the TGF beta one. Sorry. The majority of the most popular growth factors existed in the platelet concentrate is the TGF beta one. You can see here the highest concentration is with APRF plus, meaning it's more bioactive with regard the healing and bioactivity. So the accumulation of the buffy coat layer, the white blood cells, leukocytes, they are distributed amongst the whole layers rather than compressing those cells in the specific area buffy coat layer. So you can see it's like distributed in the whole area. And this is a very interesting study by Masuki 2000 et al. 2016. He compared the PRP, PRGF, APRF, and CGF, and he found that the leukocytes and the growth factors were the highest in the CGF and APRF. There is no significant difference between the CGF and APRF and as a biocompatible biocompositions. And similarly, for like specific types of growth factors, VEGF, PDGF, TGF beta, and you can see here in platelets and white blood cells. So it's very recommended. It's very interesting paper. You can download it and read it. From the recommendation, as I told you, you have to make a symmetrical distribution of the tubes. You have to put like red tubes, they're like opposing that red tubes, not the red against white tube. So this position is false. This position is correct. You can see here parallel. I have to face red against red, white against white. So it's not acceptable to put the different tubes opposing each other. Furthermore, I said symmetrical. You have to make a radius. To draw a radius, that tube should facing the another tube, not like an oblique manner. You can see here the white tubes and red tubes. You have to differentiate for preparation like the solid PRF against the liquid pair. If you have the white tubes, it's like the materials lining the tube is existent in the red tubes like silica, silicon, or furthermore we have titanium as well. So to prepare a solid vase of the PRF, we can use the red cap tube, and to prepare the liquid vase of the PRF, we can have the white tube, which is like additive free. When I say the additive, not lining free, so there is no like it's only the hydrophobic surface. And on the opposite side, we have like glass or silica coated, which is hydrophilic surface. So this distribution is correct, as we mentioned before. And I will talk about now in rush about the new generations. So I will mention those preparation in a wee description because I have to spend half day to have like a general revision and preparation. We can as well in future we can make the like course hands-on of preparation. We can make the course for this new generations. So in general, we have like making the biobone. This biobone's clue is based on the preparation of the bone grafting bone particles in the one phase, and the other phase is like a membrane. So this is the general clue behind that. Another thing is preparation of biofiller. Biofiller, from its name, we can use it like a filler in the aesthetic injection, etc. It depends on the denaturation of the albumin, and there is a specific amount size of the preparation of the albumin, and then we can include the albumin with CPRF, which is the concentrated PRF. Then we can mix those two materials together with the lower lock female lower lock. During the preparation, I can use the like female lower lock after the denaturation of the albumin. Then I inject together the both materials, CPRF and the denatured albumin. Then I can use it like the biofiller. So here, another preparation. Another preparation is the EPRF, which is the extended EPRF, extended PRF membrane. So here, the same principle I mentioned before, like taking the upper superficial area, superficial fragment of the tube, then denature this tube, put them in bioheat, then mix it with the lower portion of the plasma, then mix it together. Then I have the albumin PRF or extended PRF membrane. Okay, making sticky bone. So the preparation of the sticky bone you can see here, like chopping the clot itself, then mix the granules with it, introduce the liquid or injectable PRF together, and give it time. Then I have this amount of sticky bone. There is no time to be honest to describe it in detail, so they have the protocol. If there's any opportunity in the future, we can make a course or we can make a lecture covering those new generations. Making biograft and the same principle, we can talk about that in the future. PRF plugs, it's straightforward preparation and membrane. The same thing. I think the whole people they are familiar with the PRF membrane preparation. Now it's very important here to talk about the clinical application. Clinical application for the platelet concentrator, which especially I'm talking about the PRF. And to increase or expand the information, it's really recommended to download this 30 years autologous platelet concentrators from platelet-rich plasma to platelet-rich fibrin. It was published this year in August, I think, 2025, and by Richard Myron and colleagues talking about the like narrative review to describe the whole preparations and what is the guideline, the protocol for each single clinical scenario. We can start from the clinical application with intra-bony defect. It's plenty of scenarios like open flap debridement, with bone graft, with PRF, without. This is by Summers, this picture 2023, and I included it in my systematic review and meta-analysis. The same principle, so you can see CGF is one of the generation of PRF. But sorry, but with the recommendations here, you can see the preparation of CGF to be used with the intra-bony defects. I just left for you. I want to talk about the take-home message, the clinical takeaway recommendations for including the PRF with intra-bony defects. PRF demonstrated statistically significant improvement in probing depth reduction, clinical attachment level gains, and bone fill when compared with the open flap debridement. So it's better than open flap debridement alone. There is no statistically significant difference PRF to bone filling. So there is no statistically significant difference was observed when comparing PRF to bony grafting alone for intra-bony defects. When we compare the bony graft with the PRF, there is no significant difference between them. So furthermore here, that the addition of PRF to bone grafting results in the mild but notable improvements, including the significant improvements in clinical attachment level, gains and bone filling. So including the PRF with bone grafting is better with small amounts, not that big difference, but we gained like notable improvements. So furthermore, no significant difference was observed when comparing PRF like EMD and I think there's amniotic membrane as well. So here, whether utilized as standalone strategies or in the combination with other materials. And ultimately, the incorporation of the pharmacological agents such as the metformin in diabetic patients. So this is for diabetic. Metformin, bisphosphonates, statin-like simvastatin into PRF formulations consistently demonstrate significant advantage over PRF alone. You can see here it's recommended to add some medications, especially metformin, bisphosphonates, and statin. And for my scenario, I include silver nanoparticles. So you will find a lot of improvements during, or antibiotic, for example, a lot of improvements in by including those materials. Okay, so coming now to the gingival session, the gingival session take home message of the like what is that when I say like narrative review by Richard Mirren 2025, it's like a guideline. We are talking about the guideline take home message now. Clinical advanced flap, sorry, the coronal advanced flap calf with PRF should be considered as a treatment option when baseline keratinized tissue width is at least 2 millimeter. If it's less than that, we are tending to go for connective tissue graft, where the tissue thickness is at least 1 millimeter and there are no root steps. So furthermore, in the remaining cases, clinical coronal advanced flap with connective tissue graft and coronal advanced flap with connective tissue graft and PRF is to be preferred to achieve optimal outcomes. There remains no demonstrated superiority between the PRF, EMD, animal matrix derivatives, and the amniotic membrane in the treatment of gingival recessions. Current evidence suggests that all three modalities yield the comparable clinical results. We can see here, so it's very bioactive material. So the superiority is still for the connective tissue graft, but it's better than nothing. And I include that in my schematic review and meta-analysis about the using autologous concentrated growth factors in regenerative dentistry. It has the same outcomes. Now, another clinical scenario is which is the guided bone regeneration, GBR. You can see this study was used using the I think it's xenograft, DBBM, and collagen membrane. And the other scenario, which is C, using the sticky bone covered with the CGF membrane, to compare the outcomes. To be honest, the outcomes was not recommended to use the CGF product sticky bone in GBR case. It was positive outcomes in the short term, but it was not resistance or valid for the long outcomes. The clinical takeaway or the home message, there is a currently limited high quality. We don't have a strong evidence from the comparative artists evaluating the role of the PRF and GBR procedure. So as a result, there's insufficient evidence to substantiate the claims. We can't say that PRF improves new bone formation in this context. So in this context, we can't 100% say that the PRF is valid, very strong option for the GBR, guided bone regeneration. Animal studies similar to those conducted on extraction socket management have demonstrated inconsistent outcomes regarding the ability of PRF to enhance new bone formation, so that when combined with bone grafting materials. So still limited with the GBR. So PRF has been shown that promote early vascularization of bone tissue. It's common sense. So it's common sense we can see because it has bioactive materials, growth factors, VEGF. So it will like initiate the process of the vascularization, which is critical factor for successful new bone formation. Okay, now it's really important whenever they say we can use this CGF or PRF as a membrane for guided bone regeneration or guided tissue regeneration. So indeed, in this, especially for guided bone regeneration, it's not valid to be used by itself. It's recommended to be used like an adjunct to collagen membrane. So here it's very important outcome. So can be used like adjunct, use this membrane, membrane, the platelet concentrate, PRF, CGF, etc adjunct to collagen membrane, so it's positioned in direct contact with soft tissue rather than being used as a primary substitute of for the traditional parietal membrane. So when you use the collagen membrane, you can cover it with a direct contact with soft tissue. Okay, this is the very important aspect. Another aspect with regard the sinus elevation, um, there is a very important clue I want to talk about it is using the platelet concentrate. It's valid, but if I have contained defect, if I have a contained defect, here you can just put the material because it needs scaffold. It doesn't resist the forces, the compression, and from the surrounding tissues. So it needs that support, that scaffold. In the sinus scenarios, it's existed. In the socket, it's existed. So in other scenario, it's limited somehow. Okay. So in sinus elevation, you can see here that even the natural bone formation, it's more compared with the another material. And for example, in the study of Gaismered 2022, but this study is with concentrated growth factor, not the PRF. The home message, the clinical takeaway from this aspect with the sinus, very important. PRF has been utilized as the only grafting material in a nearly dozen studies, multiple studies. They use the PRF, and favorable results have been observed. This approach is generally recommended for narrow sinuses, less than 10 millimeter, and or cases requiring small sinus elevation. Meaning, if you have small amount of the elevation, you need to elevate the sinus just for 3 to 4 millimeter. You can use this material by itself. Okay, and PRF more commonly being applied in combination with bone grafting materials. In such cases, so PRF has been so primarily associated with slightly shorter healing period before implant placement. So it's in common sense, it will improve the healing, it will expedite, it will optimize the healing process, shorten the time of waiting. Though no significant advantage of newborn formation, they didn't find there is a difference between, from the newborn formation point of view, between bone grafting materials alone or with the combination with the PRF. Furthermore, PRF may be utilized in lateral window. So they used the PRF as a membrane covering that window. So at that window, they found like small amount of the control of the improvement of ISQ, but without significant difference. But here we found it to be equivalent between sites grafted with PRF and those using the collagen parietal membrane. There is no difference of using the PRF and the collagen membrane. And this is a merit, to be honest, of using this PRF. There's no significant difference during the covering of the window. So one clinical study found, and this is as I told you in the study of Myron 2025, that it's very recommended to use the PRF as a post-operative to minimize the post-operative pain, swelling, and the ability of the PRF to enhance soft tissue healing and closure following grafting procedure. Here, very important to say it's like it will improve the quality of life, minimize the pain, and decrease the healing time, and minimize the complications. Furthermore, as I told you before, with the contained defects like socket alveolar preservation, you can see here in this picture they used in the upper picture is the DBBM with collagen membrane, the second one is sticky bone with CGF membrane, and the last one natural healing. There's no significant difference between, it's less, but there's no significant difference between the collagen membrane and the DBBM, which is the xenograft and collagen membrane, and the sticky bone CGF and the collagen, the membrane of CGF. There's no significant difference between them. And there is a significant difference compared with the natural healing. Take home message. And before take home message here, I want to say very important aspect with using those materials like a covering membrane, especially in the cases of the sockets, open sockets. Like sometimes you'll find the area of the molars, so it's wide enough you can't draw the flap and make tension-free flap and cover the whole area. Definitely, you will be obliged to leave this area exposed to the oral cavity, and in such scenario, you can use the PRF membrane and you can leave it exposed to the oral cavity because it has immunity, it has cells, it will resist the bacteria from the oral cavity. And this is from the merits as well. These are the merits of those types of membranes. Take home message with regard using PRF in this clinical application. It's very recommended to use them to limit the dimensional changes in extraction sites compared with the natural healing. When you compare the natural healing with the PRF inclusion, it's better. Bone grafting materials has been more consistently shown to better limit dimensional changes when compared with the PRF. So when compare the bone graft with the PRF, no. Dimensional changes point of view, the bone grafting is better than the PRF. The combination PRF with the bone grafting materials has shown significant increase in vital bone formation. The amount, this is the quality, not about the quantity. So this is when I talk about the quality as well. So it's better to include the PRF with bone grafting materials. So here, it's not recommended to use bone grafting alone rather than mix it together. This approach also promotes superior stability in both horizontal and vertical. So not only in the horizontal dimensions and even in the vertical dimensions, it will optimize the healing and it will minimize the bone resorption. And a clear advantage of combining PRF with bone grafting materials. So it's really recommended from clinical point of view to include those materials with bone grafting, and we use it like membrane to cover the socket area. Furthermore, I can't separate too much between the using PRF or even CGF in the area of peri-implantitis cases, dental implantology, and GPR. So in such scenarios, there is a short-term benefit of using platelet concentrate with peri-implantitis cases, but in the long term, and this was mentioned in my systematic review and meta-analysis in my paper published 2025. But let us see the take-home message from including the PRF in the dental implantology. So this recommendation is talking about the enhanced primary implant stability. It's like at the early stages of the healing. It will studies assessing implant stability using the implant stability quotients and resonance frequency analysis. Parameters shows the minimal clinical impact. It has clinical benefits, but it's in the minimal aspects. And no histological data on bone to implant BIC are available on the data. So furthermore, there is no histological data elaborating the efficacy of this material in histological part. The furthermore, also limited available data suggests that PRF may improve soft tissue healing around implants. So again, it's all about soft tissue, soft tissue, soft tissue. It's good for soft tissue. Why? Because it's valid no more than 2 weeks. And that's why I included in my study new generation, it will resist the resorption. That's why we can include it for further clinical indications. The final clinical scenario is using the PRF or CGF and the third molar surgical extraction. It's really important to include the PRF in every single scenario, especially for those cases with smoking, diabetic patient. You can just use the platelets, PRF clots, CGF clots, and just you can put in them the socket in the area and defect and close it, and you will find very positive feedback. comparing to the nothing. So here, the take-home message of the clinical takeaway of including PRF with the third molar extraction. PRF enhances soft tissue healing. We agree upon that. Utilize in the outer barrier membrane, leading to minimize the VAS, the visual analog scale, and reduce like patient-reported pain levels. It will reduce the pain and it will minimize the amount of consumption of analgesic or painkillers. Furthermore, it's recommended, as we mentioned before, PRF significantly reduces the incidence of dry sockets and postoperative discomfort following third molar extraction. So, especially in cases, you will expect that this case will develop the dry socket, so it's recommended to use the PRF or CGF whatsoever. And I want to thank you very much for your attention. It's a really, really long lecture, but I try to minimize it as much as I can. It's not straightforward to minimize it, even that I will remove some of the quality aspects of the lecture. But in the future, we can contribute to furthermore talk about the new generation and clinical applications with the new generation as well. Thank you very much. And if you have any questions, please don't hesitate to email me via this email. And I can say, Assalamu alaikum wa rahmatullahi wa barakatuh.